It gives me great pleasure, ladies and gentlemen, to introduce to you Professor Alan Kermode. Some of you will know Alan before. Let me tell you that I've worked with a number of neurologists, and Alan is unique because not only is he one of the sharpest knives in the drawer, he also speaks a language that we can all understand. And Alan tells me that if you ever watch those movies, you know the ones where the opening scenes, there are so many images and there are so many things going on, and after the first 10 minutes, you look at whoever you're watching it with and you say, I don't think I'm ever going to understand this movie. But then by the end of the movie, all the bits come together, and hopefully we all live happily ever after. That is Professor Kermode's presentation. Please welcome Alan Kermode.
Thank you, Marcus, and really the efforts of the MS Society of WA with Marcus's supervision has really been nothing short of extraordinary. In fact, it's been more than 1 million per year for the last 3 years, and that's for the efforts of the WAMS Society, but also of the members and contributors and of really the West Australian people who've made that possible. All right, so first slide. Now, I grew up around here in Como in the 60s, and it didn't look like this when I was here before. It was really quite nice and extraordinary here. So as a child, I've got some very nice memories around here, and also some awkward ones as a teenager wearing short pants at dancing classes, being intimidated by much more sophisticated girls at the school. So today's talk, I'm going to give a quick run through of where we've been from and come with MS, because when I actually graduated, it was going to be another 12 years before there were any treatments for MS whatsoever. And it's taken a lot of work to get to where we are now. So what I'm going to talk about is where things started from and the journey I took as a young doctor and working with Ian McDonald in London, and my time in Oxford after I graduated here as a local graduate. And I spent 10 years away, in fact. So that was me in 1984 when I graduated. And from there I went to Oxford because all young people like to do something different. And then I did my house jobs in Oxford, and that's me at the Radcliffe Infirmary. When I was working there, they said, well, why don't you decide to do neurology? And I said, well, that sounds pretty good. But of course, I was very junior doctor at that time, but I think they said, if you want to do neurology, you need to work at Queen Square. So they introduced me to Ian McDonald, and he said, we have just the thing. MRI had just been discovered, and they were looking at it with MS. And since no one knew anything about MRI in the 1980s, I was as good a choice as anyone because I had a background in physics, but I was not a neurologist at that time. Whilst I was there, I was fortunate to have the inspiration of other neurologists such as Ian McDonald and David Barnes and Alan Thompson, David Miller, and we were very productive looking at ways of using MRI to study MS and what actually happened in MS, including the fact that we should separate primary and secondary progressive MS when we look at clinical trials, and that predicting the course of MS was not that easy with MRI. And we pioneered spectroscopy in MS and the behaviour of lesions and the early events. We developed tools to look at tissue perfusion and blood flow, which even today in 2015 is being used as a reference. And importantly, as part of this work, we found that some MS lesions had a lot of destructive damage and empty space, and none of the pathologists at the time had written about this, and we said, well, this is what we find in vivo. And the pathologist said, yes, well, you're right, actually, but we thought this was just a mistake. So here you find a normal MS lesion with lots of cells, and here, I'm sure you can perceive, there's just sort of empty space there, and that's what we call a black hole. So we documented the black holes in the late 80s, and I was very disappointed to find out that they're called black holes and not Kermode's crypts, because I think that would have been much nicer. But anyway, I then decided to train as a neurologist, and I thought, and once I'd qualified as a neurologist, I felt I wasn't quite finished, so I spent 3 years, some in Washington DC, the National Institutes of Health, and also back in Oxford, on the bench so that I could understand the basic scientific research. Now, with respect to genetics, something did go wrong, and I had these 2 boys, which we successfully cloned, identical twins. And so I decided to come back to Perth, and that was 1995, 11 years after I began my journey. Now, of course, in 1995, and I came to work at Sir Charles Gardner, which you can see there, there was no MS clinic, and in fact there were no MS treatments. But nevertheless, we started an MS clinic with the principle that if you can do basic research, ultimately that will be able to bring benefits to the patient. So initially it was just me, and we got involved in a lot of clinical trials, and here are some of them. And a few people here might remember the linamide trial, and that was the first trial of MS drugs here in Australia, well, the second actually, but the first tablet trial. And unfortunately, the drug was withdrawn because of safety concerns, although it was positive. And it was shortly after that the beta-furon studies were published, and we're involved in all these studies. We also took on some more hazardous therapies at certain times, such as mitoxantrone chemotherapy, which received FDA approval, and also stem cell transplantation. We reached out to become part of MS Base when it began, and these other collaborations. And we're currently the curators of the National MS Research Association Stem Cell Transplant Registry. Now, this is a typical Friday afternoon before Journal Club on the Monday, and there's a lot published about MS. And I can tell you it's not an easy job, because a lot of what is published is either not completely precise or not necessarily helpful. So it's quite a confusing business. We have a lot of slides in the beginning of the talk, but towards the end we'll slow down and focus. I'm trying to set the scene of how busy it can be. But in 2005, Professor Bill Carroll, who you can see here, who had a long association with MS in Australia, managed to be persuaded to join our clinic, and we got 2 PhD students, Dr. Jingshan Wu and Dr. Peter Chu. And thanks also to Professor Frank Mastalia here, who supported us all the way through the WA Neuroscience Research Institute. Sue Walters, who some of you may have met, is our clinic coordinator. Without her, none of our trials would have worked. And 2 other fellows we've had, Dr. Ju and Dr. Law. And this is Dr. Marjana Fabis-Pedrini, who's our current research scientist. All of these people, with the exception of Marjana, were funded via scholarships, either through University of Western Australia or through the Australian government. So as you can see, it took 11 years of running clinics to get to that point where we accumulated a large number of patients, and here you can see the age range of the patients. And currently, thanks to the participation of many people with MS, we now have 1,400 patients who've agreed to be part of our studies. Early on, we looked at things such as fatigue using electrophysiological principles, and subsequently, once Dr. Wu had started, and then Dr. Chu, we managed to look at a lot of clinical features, including genetics, and this quite important paper, I think, which I'll explain a bit more, and that is Dr. Joseph, who was another fellow who worked with us for 1 year, funded by the Malaysian government. And through our studies here, we found a number of interesting things. Now, genetics is quite important, but I will stress that genetics is not the cause of MS. Genetics is who we are, is what influences how MS behaves and what our risk of developing MS might be. And towards the end, hopefully I'll tie some of these issues together. But you can see here, if we look at different genes, and we're all different, depending on which combination of genes you have, if you do develop MS, you can see it can be a more than 20-year difference in the age at which you develop MS. So these are quite significant findings. We also found that your genetic makeup, in other words, your background, determines whether or not you develop oligoclonal bands in your spinal fluid. And now across Asia, this is an issue because in Western literature we say the spinal fluid has to have oligoclonal bands for you to have MS. But it turns out if you have certain genetic types, like here, you'll never get oligoclonal bands. So people were actually experiencing MS and had MS, but were not able to be properly diagnosed just because they happened to have a different ethnic background to the typical white Anglo-Celtic person in whom all the British and North American research is done. Now, clearly environment is the dominant factor that influences the risk of MS, and we'll hear more about that after my talk, but perhaps nowhere is this more evident than in the Far East, in Asia. As you can see, in the 1950s there had only been 270 published cases of MS in Japan, and now there's more than 15,000. And the character of that MS has changed also. And in Japan, as in Australia and New Zealand, the further away you go from the equator, so that in their case, the further north you go, the greater the risk. So up here in Hokkaido, the risk of MS is very much higher than, say, in Honshu or Kyushu. So we reached out to the Far East because it was an area that was untapped with good health systems, particularly in Korea and Japan, good scientists, and importantly, funding, and most importantly, things to be discovered. So here I travelled a lot, and here in Korea, meetings in Japan. We established the Pan-Asian Committee for the Treatment and Research in Multiple Sclerosis, which is now quite a big and productive organisation. Travelled to the areas of China, for example, this is in Guangdong province. This hospital group has a catchment area of 70 million people. So this one hospital group looks after almost 3 times the entire population of Australia. And of course it wasn't all hard work, and I did have an advantage. This is my wife. So who speaks a number of languages, and we didn't have any problems with communication. As a result of this, we had a number of collaborations which were successful, looking at optic neuritis, and unsurprisingly, really, I think, MS in Asia is not actually that different from MS in the West, because it is MS. Now, another thing we were very interested in is grey matter in MS, and it doesn't show very well on MRI because we've been telling radiologists that it's a white matter disease, but it clearly can be a grey matter disease, and we looked at great detail in new methods, and we also looked at the hypothalamus, which other people hadn't looked at closely before, demonstrating that injuries from MS there are very common, and of course this is related to energy and fatigue and other very important issues that many people experience. So we're searching for answers. We reached out and established local collaborations with immunologists and other scientists. And this is quite important. And in particular, I want to point out to Professor Simon Worrall, Professor Nolan, Professor James and Professor Hollingsworth. He's a biostatistician and these are immunologists, because they can approach the science from a different point of view. Professor Worrall in particular has great experience in HIV, and you may say, well, what does that have to do with MS? And actually, probably not much, But the processes that are involved in human disease have a lot of commonality. Other synergies through Neuromuscular Research Institute, Dr. Gosh looking at balance, and some of you may have met him in the clinical trials we're trying to improve balance. Michelle Burns with her work in anxiety, stress and depression. And Steve Wilton, whose primary area has been muscle, but the technologies developed there may be useful in the future for MS. Importantly, collaborating with Professor Malal gave us access to the extraordinary technology available through the IIID. That's their building, and that was funded by the Bill and Melinda Gates Foundation from Microsoft. And here's their fully automated high throughput gene sequencing. So my philosophy has been, if we can get as many intelligent people as possible interested in finding the cure for MS, and even better if they can do it with their own funding and money, because we don't have enough, then that's better for everyone. We got international recognition. This is at ECTRIMS, speaking to 4,500 people, and exposure. Professor Carroll doing editorials for the New England Journal of Medicine, and consensus statements. So globally, the quality of the work done in Australia, not just Perth, widely acknowledged. In fact, Professor Carroll and myself, in the last decade at University of Western Australia, we're the second highest cited authors over the last 10 years across all fields, including politics, law, economics, and we know how much they talk. And what I'm showing off, what I'd like to say is that all this work Dr. Carroll and myself have done for MS has been pro bono. It's all extra. We personally don't receive any funding for this work. We collaborated nationally, and in fact, Australia has really been leading the way globally in studies of genetics, and that's just me, not very important at the back. Catching a ride. But from Australia, a number of great work has happened. In fact, Australia found the second gene ever to be associated with MS, and subsequently we've collaborated globally, and there's no conspiracy with MS. MS research is an area where everyone on the planet can agree to all be pulling in the same direction. And this discovered many more genes related to MS, and subsequently more again. So you may say, well, why haven't we solved it? But as I mentioned at the beginning, MS is not caused by something you inherit. What these gene studies tell us is the machinery of the body that's involved with MS, and allows us to think about targets for new treatments and research. And we've also spread this to Asia, to China. And interestingly, Chinese people have similar associations to Western people for the risk of MS, but the effect is much weaker in Asia than it is in Australia. Now, a very important talk following after me is to do with sunlight, vitamin D and the story. So I won't steal the thunder, but what you probably know is that, we think the more sunshine you have, and that includes ultraviolet, the less likely you'll get MS. Not impossible, but less likely, and I'll explain that a bit more. But there are parts in the world where it's back to front. Now, once you have a clue like this, it obviously gives you a target to study. And this will be discussed after me, so vitamin D and ultraviolet clearly important. And what's more curious, I think, is, at least in the Northern Hemisphere, if a woman is pregnant in the winter, when we might expect her ultraviolet exposure is lower, the risk of MS in her children 20 years later is higher. And if she's pregnant in the summer, the risk of MS in her children 20 to 40 years later is lower. And in terms of conventional genetics, that doesn't make a lot of sense, because it may be something happening when you're in the uterus, or even something happening to the genes unrelated. So we know the risk factors include ultraviolet, vitamin D, hygiene, and glandular fever, or the Epstein-Barr virus, and we'll go into that a bit. So how can we tie it together? So we looked here at what we call vitamin D response elements, and that's how vitamin D affects your body, and what we already know, the genetic risk. Now, the genes with the absolute lowest risk of developing MS are also the genes that have the most negligible response to vitamin D. So we're beginning to get some consistency in the story. And this is the raw data from our group. And if we summarise that, we find there's certain combinations of genes which give you a lower risk of MS, and certain genes that give you a higher risk. And in fact, the very lowest risk genes to the highest risk genes make quite a big difference, some 20 or 30 times difference in individual risk. And put another way, explaining how this works is very important. But this is just an observation, it's not the answer. So we've decided to look at other factors. We know glandular fever, the Epstein-Barr virus, is important, and hygiene. Now, 92% of Australians have had the glandular fever virus, Epstein-Barr virus, but 100% of MS people have had it. So that's probably important. So is kissing dangerous? Well, my experience has been it certainly is. But that's how we catch Epstein-Barr virus. And so it may be a combination of factors. How old you are when you're infected, how much glandular fever you have, and what your body is like, and whether or not the virus can mutate to escape. And this gets more interesting if you look at different countries. If you live in a low hygiene area like Africa, by the time you're 3 years old, pretty much everyone has got the glandular fever virus. Probably because your mother might be chewing the food to give it to you, but you know, viruses are everywhere. But if you live in Como, you're probably not going to get the glandular fever virus until you're a teenager or a bit older. Or in my case, until you're much older, unfortunately. And there is an association with having the glandular fever illness or being ill and the risk of MS. So it's tempting to speculate that there's some relationship, and that might also explain why in the United States, where there are big gaps between the rich and poor, that the risk of MS in poorer people is lower than the risk in wealthier people. So how can we tie it together? Well, if we look at the way your immune system tackles the glandular fever virus, and we correlate it with your genetic makeup, we find, in fact, that a test can be 80% specific and 80% sensitive. So it does appear it's some interaction between the kind of virus, your immune system, and so the hypothesis might be that a number of things would happen. Your background, your childhood, your vitamin D, sun exposure, maybe what your parents did or even your grandparents did. You happen to come in contact with this virus, the glandular fever virus, of which there are many different kinds. And depending on how that all happens, you might develop response to your own proteins and develop MS. Of course, it's only a theory, but if we look at it this way, no one feature is enough. It's an interaction between all of them. And to quote John Donne, no man is an island entire of itself. Every man is a piece of the continent, a part of the main. So no doubt there's a complex series of events that happen to give us the risk of MS. And this brings us to a study we did trying to solve the hygiene theory. Is too much hygiene not a good thing? And one of the best bits of this study is that our research fellows got to meet a Nobel Prize winner, of course Barry Marshall, and actually hold the Nobel Prize. He insisted this was just the chocolate one, not the real one. So we looked at a control group of people versus age, sex-matched people to find out did they have the Helicobacter bug, the stomach ulcer bug. Not because we think the stomach ulcer bug is the cause of MS, but because it's a good marker of how hygienic your background was. And as I mentioned, being too hygienic is not always a good thing. And I don't expect you to read this, but the upshot was that if you had been colonised with the stomach ulcer bug at an early age, and you're a woman, it had actually reduced your risk of developing MS later quite significantly. Now, of course, the Helicobacter bug's not necessarily a good thing because it can cause stomach ulcers and make you quite unwell. And that's much more likely than it is people getting MS. But nevertheless, it was quite compatible with the concept that the kind of exposure you have as a child influences your risk of MS. And we also know that as our societies have become healthier and wealthier, the number of people colonised with this bug becomes less. So it is a very interesting association, and it attracted a lot of news globally because it was the first objective evidence that this hygiene hypothesis might be right. Now, what's epigenetics? You might have read about it. Well, that's a principle that genetics is more complicated than you learnt at school, and that Mendel, who did the original genetics experiment, probably cheated in his experiments. And it shows that maybe what happened to your mother and your grandparents can affect what happens to you. And we know that this does happen in the agouti mouse. And depending on the environment of the parents, depends on what the offspring look like. And that's because genes have what's called methylation, which, to summarise, just means it's a lot more complicated than we've thought for the last 30 years. So what have we done here? Well, there's been a lot of news about stem cell transplantation. And I think you know the idea. You have some chemotherapy, some bone marrow is taken out, and then your own bone marrow is put back. 15 have been done here in Western Australia, and I'm sorry to say that no one has had great improvement. However, in the small number of people in whom it might be suitable, and we've followed people up for 7 years, some people have gone some significant time with no progression in their disability. So perhaps for this very small number of people for whom this treatment might be useful, that's a good outcome. But I present this as a slide number one to show that we neurologists look at everything, but secondly, there are great dangers with certain treatments, and including mortality with a procedure such as this. So MS is not simple and it's not black and white. So for the moment, this is a good treatment for mice, but keep watching this space and we'll let you know when we've got it sorted out. We've also been looking at what makes the difference between someone who has optic neuritis or an attack of first attack, if you like, and then goes 20 years being fit and well, or someone having other problems. Clearly this would be useful for us if we could predict this. Which brings me on to some of our current trials. The first one is FOCUS, and the second one is a study for secondary progressive MS. Now, as many of you here know, MS begins when people have a first attack or a first symptom, and we call that a clinically isolated syndrome. That might be optic neuritis, it might be numbness or tingling, but not everyone who has an attack like that goes on to develop MS. This study is to try and find out, number one, why do some people go on to develop MS and others not? And number two, can we prevent it? And it's doing that by giving people narrowband ultraviolet radiation. So not exactly a sun lamp, but a bit similar. And the key to this is a lot of detailed immunological testing supervised by Professor Hart, who's here in the audience, to establish what immune events happen when people have an attack, how does it change after the attack, and can we look at differences between someone who's going to go on to develop MS and someone who's not? Because if we could tell that early, it could revolutionise how we treat MS and hopefully be able to prevent it. The second study is for secondary progressive MS. Unfortunately, we don't have any good treatments for MS yet to stop significant progression once it occurs. We're very good at stopping attacks at the moment, but unfortunately many of those medications have not been useful for stopping progression. So this study is what we call a phase 2 study, which is very early in the development of medication. And it's a weekly infusion of the medication, weekly for 12 months. And again, with many immune studies. Anything that might be useful, we work hard, and the WA MS Society works hard to bring to patients. And we continue to help places elsewhere in the world where they can't afford treatments that we can afford here, other strategies. So this is our current plan for the future. We're trying to understand the basis of MS. We're looking for biomarkers, blood tests. We're trying to draw a link between vitamin D, sunlight, glandular fever, and people's genetics. We're trying to target early MS to prevent it with phototherapy. We are the national curators for the stem cell transplantation research, but I should emphasise it is research, not a proven treatment. And we've also been involved in genetic predictors of interferon response, because it would be lovely if we knew what the best treatment for an individual would be at the beginning, to say to them, look, interferon's not going to be good for you, rather than have to try it for 6 or 12 months and find it's not helpful for them. And other issues. So a lot to look forward to, including teaching the next generation of neurologists and working hard to establish further funding and to get the same kind of research funding as, say, the military can, or other things which seem a bit more sexy than saving lives. So it would be lovely for us if solving MS was black and white and it was simple when we'd miss something. This is in the Miro Museum in Barcelona. One pencil line on a white piece of paper, and it's worth more than my entire lifetime salary, I suspect. But actually MS is more like the night watch in the Rijksmuseum. It's very complicated and there's a spectrum of issues and we're working on it. So thank you for your attention, and thank you.
Is there any questions for Professor Kermode?
Yes, sir. Well, you're right to be cynical, because the news never quite gets it on the button. And over the last 20 years, we've heard of the cure for MS at least 20 times that I can recall. However, there is a new drug for MS. It's called alemtuzumab, and it's taken a long time to get this drug approved. It is a form of chemotherapy. So it is for relapsing remitting disease, and particularly for relapsing remitting disease that is refractory to other therapies. That's probably where it'll be used. However, don't give up hope, because the last 2 years have seen a sea change in the research priorities of both researchers and big pharma to look at progression per se. You know, the people now with relapsing remitting disease who've just been diagnosed are very well served. We have superb medications for them. But there's been a gap always for people with primary progressive disease and people with secondary progression. And there's now an international MS alliance, the Progressive MS Alliance, and it's received funding from the European Union, which I think is a great initiative because really, for the first time, governments have been chipping in because they realise that the current paradigm, it's too difficult for some of the pharmaceutical companies to approach on their own. So currently, as we speak, there are many medications and research trials looking at progression and also repair, such as anti-LINGO, LINGO inhibitors and other basic research. But that pathway will have to come from basic science. It's not going to be as simple as just saying, well, we've not tested this before, let's give it to 500 people. Yes? No, not at present. And I like to think of the statistics as saying, well, do the children of people with MS have an increased risk? Yeah, they do. But if I buy 2 lotto tickets this weekend, I've got a 200% increased chance of winning the jackpot. But my chance of winning the jackpot is still not very big. So, as a generalisation, if you're living in Western Australia and a family member has MS, then the children, depending on if they're boys, girls, mothers, fathers, blah, 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 give or take, it's pretty accurate to say it's about 100 to 1 against that they're going to develop demyelinating disease in their lifetime. Now, that is significantly more than 1,000 to 1 against of everyone else, but 100 to 1 against is still pretty good. So the most important things are still, where are they, who are they with, what time they're coming home, do you know what their views are on smoking and drugs and things. And of course, if they're children now, and given that we had nothing prior to 1996 for any kind of MS, and then nothing else really significant till 2007, hopefully we will have got a key to it by then. And just for everyone's comparison, risk of breast cancer is 1 in 7. So that kind of puts it in perspective a little bit. Yes, we had one other question. Yeah, so the real question here is, does it help? And that's an answer that they can't answer. And there's an operation in Queensland doing various things. But the point is, you've got to ask, does it help or does it harm? Now, in the absence of any evidence that it helps, so let's say you've got cells from fat. A number of things have to happen for it to be useful for MS. First of all, does putting adipose cells into the body alter your immune system much? And the answer is no. So it doesn't seem likely that's going to affect MS. Do cells from fat migrate to the brain and repair myelin? Probably not. It's never been shown, not even in animals. So I think there's a lot more work needs to be done there. There's also work on mesenchymal stem cell transplants, and in that case, those stem cells are not the patient's own, and they do not survive when you put them in. So they're dead within hours after you inject them. However, in some conditions like Crohn's disease, it can produce a change in the human body's immune system. But, Crohn's is not MS, and studies are going on with mesenchymal stem cell transplants. But, I can say you need to recall that many things that people do to MS can make things worse. So, for example, when interferons were first discovered, they tried interferon gamma, and that increased the risk of an attack 6 times, and the study had to be stopped. Places like Macquarie University where they're researching it, there's no big trial in MS. And if people were having attacks, you wouldn't know if it was making people worse or better, because there's no sort of validated way of assessment. So it's work in progress. The important thing is that globally, we're all pulling together. But if anyone asks you for money to have a stem cell transplant or something like that, then there's something wrong with the system. Because, for example, if your neurologist feels a stem cell transplant, a bone marrow stem cell transplant is going to be useful, it's free, because we live in Australia. If people are paying to go to Russia, they're paying because the advice here is that it's not going to be helpful. There'll always be people ready to take your money, unfortunately, when you're desperate.
Right, thank you so much for your presentation, and I'm sure you'll agree that we've got someone who's very much in the know and at the top of the research and can really give us some sound advice. So thank you for your time and coming.
And thank you to everyone here too.
I'd like to now call on Ollie and Anne to come on up and to do a presentation for us. They are in our physiotherapy department, looking at the assessment and treatment of balance issues. So we look forward to hearing from you guys. Thanks.
Good morning. My name is Anne Worrall and I'm a physiotherapist. And this is Oliver Guttinger, and he's an exercise physiologist. And we both work together at the MS Society. Do you remember writing out that survey last year? Well, when the results were analysed, it showed that lack of balance was the third most troubling symptom. So today we've been asked to talk about balance. I'll talk a little bit about the balance systems, and then the physiotherapy assessment, and then Ollie will talk about the balance master. And afterwards, how we pull all this information together to formulate a treatment program. We'll leave time at the end for questions. This is the ultimate in balance. Balance is very complex. Balance is the ability to remain upright when we're standing still or moving. And it requires us to keep our centre of gravity over our base of support. If we move our centre of gravity too far out, we'll fall. This is a very simplified diagram of the balance system. Every time we move, our bodies are required to adapt to a new posture. They need sensory information taken in from the environment, they take it into the brain, and then produce a motor response to the changing activity and the changing environment. The sensory input, this is from the vision, the vestibular system, and from the somatosensory system. Vision is critical in our balance. It allows us to identify objects, to determine their movement, and then how they are in relationship to us. We often rely on our vision for balance. Our vision works closely with the vestibular system so that when we move our heads, our eyes stay focused on the object that we're looking at. The vestibular systems in our ears, they're the semicircular canals, the utricle and the saccules. And these tell us when our head and our body are moving. It relates to gravity and rotation and acceleration and deceleration. Whereas the somatosensory system, this is the sensory system from sensory input from our muscles, our joints, and from our skin, feeding into the brain to produce a motor response, an automatic one that allows us to keep our balance, so that we know where our hand is without looking, because the proprioception is telling us. And we know what kind of ground we're walking on because of the sensory in our skin. And it also tells us about body sway. So some of the tests that we do to test the somatosensory system, for touch, we use a tissue in various parts of the body. We use pinprick and ask if you can feel them. For proprioception, we ask you to close your eyes and we will move your joints and ask if you know which way we're moving them. And then we do a test called the CATSIP test, and this is the clinical test of sensory integration and balance. This tests how your vision and your vestibular and your somatosensory systems are working together. And this is really the cheap $60 version of the Balance Master. So Ollie's going to demonstrate it for me. First of all, to get our baseline, Ollie's got his eyes open, he's got his arms folded, and he's got his feet together. So here he's got available his vision, his vestibular, and also his somatosensory system. Now, the next one we do is we ask him to close his eyes. So now we've taken away his vision, but he still has his vestibular and he still has the somatosensory system. So if a poor performance here might mean that he's a bit reliant on his vision, and maybe his vestibular and somatosensory systems aren't working quite as well as they should. Now, if I ask Ollie to stand on the phone with his feet together, he's got his eyes open, so he's got his vision, he's got his vestibular system, but I've compromised his somatosensory system. And a poor performance here might mean that he's a little bit over-reliant on his somatosensory system, and maybe his vision or his vestibular system is not working quite the way it should. Now, of course, I'm going to ask him to close his eyes. So he's only got his vestibular system working here. And if he does fall, it probably means that it's not working too well. But you can get off now. Thank you very much. However, the sensory input is not the whole story. We need to look at the motor output. So for this, we look at the range of movement. Have you got enough range of movement in your joints? So for instance, does your ankle come up far enough not to trip you up? Sorry. And then we look at the muscle strength. Have you got enough muscle strength to lift your foot or to lift your leg? So we test your muscle strength. We look at the tone. Have you got a bit of high tone, some spasticity, or low tone? And then we look at how coordinated your movement is. Is it smooth? And then we look at the automatic responses. So we ask you to reach as far as you can out to your limits of stability. And then we might even give you a little push to see how well you react. And then to look at the functional activities, we do the Berg balance. Now this looks at static balance, so sitting, standing with your feet together, tandem stand, and standing on one leg. It also looks at dynamic balance. This is reaching, picking things off the floor, steps, and that sort of thing, and turning. And these all give a good indication as to where we need to be practicing. And then we do the walking tests. So we do the 10-metre walk test. Are you able to walk fast enough to cross the road safely before the light turns to green? The 6-minute walk test is an endurance test. And then the functional gait assessment, this is where we ask you to walk with head turns up and down, walk backwards, walk with your eyes closed, and then the timed up and go. This is one about you sit and you have to walk 3 metres, come back and sit down. And then we ask you at the same time to count backwards or to carry something in your hand. This is to sort of test out your divided attention. These all give a good indication as to where we need to be practicing to improve your balance. However, a valuable part of the assessment is the fear of falling questionnaire that we ask you to fill out. And then a diary for falls, trips and slips. It's a good idea if you fill these in. And again, we then know where to practice. So we pull all this information together to make a treatment plan. And as you can see, the physiotherapy assessment's a little bit subjective, whereas the balance master will give us a quantitative result. So now I'll hand over to Ollie.
The balance master falls into the domain of balance assessments that we call computerized dynamic posturography. I'm just going to call it CDP from now on. The techniques used in CDP were initially developed with support from NASA. Obviously, they were very curious as to see what happens to astronauts coming back to Earth from a zero-gravity environment, and obviously wanted to evaluate how their balance systems were performing, and then to reassess them after an intervention to see if they could measure any changes occurring to them. It's a sensitive piece of equipment, the Balance Master, which I'll talk to you in a bit more detail later. And it's considered to be the gold standard for the evaluation of balance. So Anne just talked to us earlier about the three major components that comprises balance. So we have our sensory systems, vision, somatosensory systems, our vestibular system. We also have a brain that uses this information that it receives from our sensory systems. And finally, there's the motor output component to this. And so CDP is a series of testing procedures to evaluate each of these components. This is a picture of the Balance Master that we have housed in our Wilson office. So CDP evaluation requires some specialised equipment. It costs a few bob more than a piece of foam. So it's a consists of a movable force sensing platform. It also has a movable visual surround. And it has a computer that drives the whole thing. So the computer processes signals from the force sensing platform and is able to quantify a person's postural stability, okay, under different sensory or environmental conditions. Oh yeah, and it's probably worth mentioning that it's also safe. You're strapped into a harness. Anne also talked a little bit about sensory organisation. So sensory organisation is a person's ability to, I guess, process the different sensory information that the body's receiving and then to give an appropriate motor response. Balance Master has 7 different assessment procedures. I'm only going to be talking briefly about one of them today, and it's called the sensory organisation test. And so it effectively or quantifiably measures a person's sensory organisation or a person's ability to use their 3 main senses. So similar to, it sort of mirrors that CAT-SIP test that Anne put me through a moment ago. So we have 6 different sensory conditions or environmental conditions. Is this a laser? Ah, yes. So we have our first condition. This is just measuring static standing. The platform, the support platform, is stable. The visual surrounding screen is also stable. And we're just capturing that data for about a 20-second period of just simple standing, eyes open. Second condition, same thing, except this time you're doing it with eyes closed. So it gets progressively harder as we go along. Condition 3 is now exposing the person to a movable visual surround. Okay, so now we're testing a person's ability to suppress the visual information that they're receiving because it's inaccurate, it's unreliable, and we're testing a person's ability to suppress that and then to select a more appropriate sense. Okay, in this case it would be the somatosensory system, vestibular system. Condition 4, the support platform now starts to move. The visual surround is fixed, so we're getting stable visual cues, but now we're getting unreliable or inaccurate somatosensory cues because the floor's moving. So effectively we're assessing somebody's ability to use their visual system. Condition 5, we're doing the same thing again, except this time we're doing it with eyes closed. Okay, support surface is moving, eyes are closed, we're not receiving any visual information, we're receiving inaccurate or unreliable somatosensory information. So this is really looking at a person's ability to use vestibular cues for postural control. And last of all, Thank goodness, eyes are open this time, but everything's moving. Yeah, the visual surround is moving. The support surface is also moving. And we're going to have to negotiate that environment mainly with our vestibular system because the other two are compromised. So as I said before, the computer processes the signals that it receives from the force plate, from the standing platform. And it runs a series of algorithms and calculations to basically discern where that person's center of gravity is. And so it's able to detect subtle shifts in our center of gravity. And this is how it is able to quantify a person's postural control. And this is the beautiful graphs that we get after running someone through the sensory organization test. Okay, so we get a bunch of green markers, we get a bunch of red markers, and shaded in the back is sort of your age-related normative data. It's your comparison to your healthy counterparts, if you will. So we have an equilibrium score, and you can see, according to the norms as well, that as we progress through conditions 1 through to 6, that normative data gets lower and lower and lower. So it gets progressively harder as we go through the conditions. We also get an average or composite result. And I'm just going to briefly go into some of these things here. This one's pretty cool. It gives us a measurable result for a person's somatosensory system, how the somatosensory system is performing, how the visual system's performing, how the vestibular system is performing, and whether or not they're displaying a visual preference. And I'll explain that a little bit more a bit later. So how do we get these scores? Back in that sensory analysis here, we get those by comparing our equilibrium scores against one another in those different conditions. So everything's pretty much compared back to our baseline in condition 1, static standing, stable support surface, stable visual surround. Everything's compared back to that. And Anne's gone over this briefly too, so I won't go into it too much. So it's basically comparing condition 2 against condition 1. That's looking at how well your somatosensory system's performing. Condition 4 against condition 1 is evaluating how well your visual system is performing. Condition 5 against condition 1 is how well your vestibular system is performing. And then we have a look at conditions 3 and 6 against conditions 2 and 5. So this is really looking at how your performance when the visual surround is moving in conditions 3 and 6 against when your eyes are closed. So really what we're looking at here is the degree to which a client relies on visual information to maintain their balance, even when that visual information is incorrect. So someone who displays a visual preference, and we do see it quite often, to put it in a practical example, say for instance you might be standing on the side of the road and a big bus comes past your field of vision and it kind of throws you off balance a little bit. Okay, next we have strategy analysis. Just from this one test, it takes about 10-15 minutes to do this test, and we get all this information out of it. We get a bit of an insight into a person's use of strategy, whether it be hip strategy or ankle strategy. Those are the two main strategies we use in static standing. It's normal and appropriate to use an ankle strategy when a person perceives that their balance is or the support surface is stable. Okay, so in everyday normal standing, we use an ankle strategy to maintain balance. Okay? When a patient, or person I should say, perceives their balance to be unstable, the center of gravity is reaching their threshold of support, then it's more appropriate to use a hip strategy to maintain balance control. And so we're able to track a person's results and see whether or not they're using these strategies at times when it's appropriate. And last of all, it's a pretty simple one, but it's really informative also, is that we get a bird's eye view from above looking down at a person's centre of gravity and where it was positioned over the course of each of those 6 conditions. We get an insight to see whether a person is aligning their centre of gravity within that white rectangle, within the normal range, or whether they're sort of leaning more favouring one side, whether they're positioned back on their heels a bit more or more onto their toes. This is useful because obviously when we're looking at our outermost limits of stability, if our centre of gravity is displaced in any one direction, we're moving a bit closer to that outer threshold. So it's not going to take much more to push you and in that direction that your centre of gravity is displaced and for a fall to occur. Okay, and last of all, before I hand you back over to Anne to wrap things up, the role of the balance master in the department at the MS Society. Obviously, it gives us some quantitative information about a person's overall balance profile. What this does is gives us a bit more of a clearer understanding of a person's balance and gives us insights into how we can, I guess, effectively guide and choose with greater clarity how to organise somebody's treatment plan. Okay. And last of all, but not least, it provides us with an objective treatment measure, an objective assessment measure to document improvement through treatment.
So let's look at treatment now. So what we do, the treatment must be based on the assessment results. We need to target the areas that you find difficult. And so by gathering all the information from the balance master and our own physiotherapy assessment, we can really target the areas specifically. And the assessment shows very often that we are over-reliant on our vision and that we really need to challenge the somatosensory system and the vestibular system. But above all, when we do balance exercises, we need to be safe. Balance rehabilitation needs to challenge your existing level of balance in order to improve it. And this often involves activities that decrease your visual and your proprioceptive input in order to challenge your vestibular system. This means closing your eyes and walking on foam and grass and things like that. Standing with your feet in different positions. If you stand with your feet apart, you've got a wide base of support and therefore you tend to be more stable. So by progressively bringing your feet together, we make it harder for you to balance. We do walking with head turns up and down, walking and talking, walking, carrying things. You can have obstacle courses where you've got to go round things, over things, different surfaces, carpets and all sorts of different surfaces, opening and closing doors, going down slopes, going up steps, all to challenge your balance. However, I can't emphasise enough that you need to be safe. So please don't practice unless you've got somebody with you, and practice in a safe place. A corner of a room with a big chair in front, so there's nowhere that you can fall, is a good place to try. So to sum it up, balance assessment is essential. It allows us to target the areas you find difficult, and the research shows that balance rehabilitation must include sensory training as well as the strengthening exercises. But above all, you must perform these exercises safely. So please do not do any exercises until you've spoken either to a physiotherapist or an exercise physiologist, and only practice when you've got somebody with you. Thank you. Have you got any questions?
I'm just interested if this impacts on neuroplasticity at all to develop brain pathways.
Yeah. The more you practice, the more you develop these other brain pathways.
Okay, well, with that, thank you very much. That was really informative, and having been around at the MS Society for so long, I've certainly learned a whole lot.